And we're back, and we continue our fascinating conversation with Dr. Lori Medeiros from, she's the medical director at the Rochester Regional Health Breast Center. Fascinating stuff. We've covered a lot of territory so far. Let's, if you don't mind, can we start with when to get the first mammogram? And I know that this is another gray area, and you hear differing bits of advice on this.
Right. So the controversy about this really comes out of the way that our technology is evolving. So our technology is evolving faster than our understanding of what to do with the disease. So it's not that you can't get breast cancer early. Some of it has to do with when the tools are useful and when the tools aren't. So it's very individual. But by and large, you know, I still recommend that women get at least their first mammogram around age 40. Now, clearly that can change if you're a high risk for a gene abnormality or something like that. You know, and it's important to understand that what we're finding on mammograms often are very small, very early, and there's some controversy even about these stage zeros, whether we should be calling them cancers or something else to just kind of, you know, mitigate that anxiety that comes with that big umbrella term that we were talking about. But 40 generally, I think, is reasonable. You know, and again, it has to do a little bit with what your particular situation is.
Okay. And what about choosing to have an operation to get out ahead of the disease? When to have a mastectomy or a double mastectomy, whatever the case might be?
Right. So there's a kind of a two-part to this. So, you know, treating breast cancer is a little bit separate from preventing breast cancer. So when we're talking about treating breast cancer, you know, generally our preference is lumpectomy if we can, but there are certain, you know, reasons why a woman would choose a mastectomy or would be offered a mastectomy if you're diagnosed with breast cancer. One of those reasons may be having multiple tumors. So some women come in and they may have a tumor in the upper part, the lower part, a little bit scattered throughout the breast, where it's really not a great idea to be trying to save that. On the other hand, some women do want to do something preventative. Now, preventative mastectomy, it should be noted that that doesn't entirely prevent breast cancer. It seems kind of counterintuitive, but you're always leaving a little layer of breast cells behind. So it cuts the risk by about 90%. When you want to be doing something like that is really when you're looking at a gene abnormality. So women who are diagnosed with the BRCA1, the BRCA2, that's really something we discuss with them. You know, in the context of all the options. So that may include high-risk screening to try to detect things earlier. There are drugs that we can use to cut the risk down. Oophorectomy, removing the ovary. Some of these gene abnormalities are also associated with ovarian cancer, and so, you know, those are other things you can do. But by and large, for somebody who's diagnosed with breast cancer, and you're talking about preventative mastectomy on the other side, if you don't have a gene abnormality, the average risk for developing another cancer in the future is about 0.5% a year. So it's very low.
Okay. For someone with no history.
With no
family
risk
history,
factor, no genetic abnormality, you know, so you're not talking about a 36-year-old with, you know, an average risk woman that's detected on mammogram, 0.5% a year, okay? So when you're talking about preventative mastectomy, you're doing a 90% reduction on a 0.5% risk. It's cumulative over time, but, you know, over 20 years, a 10% risk isn't that extraordinarily high for most women.